Welcome to The Explainer. We often picture modern medicine as this world of high-tech scans and instant lab results, right? But the clinical examination for leprosy, it's a whole different ballgame. It is a meticulous, hands-on hunt for hidden clues scattered across the human body. As medical detectives, clinicians have to trace the silent sabotage of a really stealthy pathogen by looking for subtle signs in the skin, the nerves, and the muscles. It's a fascinating process, so let's get right into it. Okay, let's dive into this. Here is our clinical checklist for today's explainer. First, understanding leprosy. Then, the sensory examination, palpating peripheral nerves, assessing muscle power, and finally, essential bedside tests. All right, Section 1, Understanding Leprosy. Let's lay the foundation. So to catch our culprit, we obviously first need to define it. Leprosy is a chronic inflammatory disease caused by the bacterium Mycobacterium leprae. Its primary targets, the peripheral nerves and the skin. But here is the really critical piece of the puzzle, and this is absolutely crucial. The clinical presentation isn't just about the bacteria itself. It actually depends almost entirely on the host's cell-mediated immunity to M. leprae. The battle happening at the cellular level literally dictates exactly what clues the body is going to display on the outside.
Moving on to Section 2, the sensory examination. This is where we test the surface.
To find areas where the disease has numbed the skin, doctors use these highly specialized tools called Semmes-Weinstein nylon monofilaments. Made from a specific nylon known as nylon 612, these aren't just pieces of string, they are precisely calibrated instruments. The clinician applies the filament straight down, perpendicularly to the skin, until it bows into this tiny C-curve, and that curve delivers an exact amount of pressure. They always start with the absolute finest filament, the 0.05 gram green one, and slowly build up to the 10 gram orange one. Why start so gently? Well, it's critical because it lets the doctor detect even the earliest, most subtle drops in skin sensation before any severe damage sets in. And this brilliantly illustrates exactly where this testing goes down. The World Health Organization actually recommends these exact 10 specific sites on the hands and 10 on the feet. The clinician works systematically through these spots, basically testing the distribution of the ulnar, median, and radial nerves on the hand and the deep peroneal and posterior tibial nerves on the feet. Mapping out these precise locations helps doctors grade potential disability and track exactly which nerve branches are currently under attack. It's kind of like mapping out a battlefield. Now, the investigation definitely doesn't stop at the hands and feet. Imagine you are examining a patient's eyes. You have them turn their gaze away, just to avoid involuntary blinking, right? And then, coming from completely out of their line of vision, you lightly brush the cornea with a fine wisp of sterile cotton. What we're checking here is the corneal reflex. A delayed or totally absent blink isn't just a simple eye problem, it's a major clue signaling that the facial nerve is involved. Section 3, Palpating Peripheral Nerves. It's time to find those hidden clues. Often, the clues we're looking for are literally hiding in plain sight. Take a look at this image showing the side of a patient's neck. See that raised cord-like structure crossing the sternomastoid muscle? That is a thickened greater auricular nerve. Clinicians don't just look at it, though. They feel it. They palpate these nerves to answer some really crucial questions, like, is it enlarged? Is it compressible? Does it feel nodular? And maybe most importantly, is it tender to the touch? The ulnar nerve, which is located right in the groove at the inside of the elbow, the medial epicondyle, is another prime suspect. The clinician will flex the patient's elbow, locate the nerve with their left little finger, and actually roll it. They're physically comparing its thickness and texture to what a healthy nerve should feel like. I mean, it requires a highly trained touch to spot that subtle thickening that screams chronic inflammation. So what does this all mean? How do doctors consistently quantify this kind of damage? Well, they use a specific grading scale. A grade 0, which is a normal nerve, feels soft to firm, flattish, and slightly compressible. But as the disease progresses, the texture completely transforms. A grade 2, a moderate thickening, feels rope-like. And by grade 3, severe thickening, the nerve feels straight up nodular or beaded. This table gives doctors a universal language to track the structural ruin of the peripheral nervous system. All right, Section 4, Assessing Muscle Power, Testing for Mechanical Failures. To systematically measure this loss of function, clinicians use voluntary muscle testing, or VMT. It's a standard 0 to 5 scale. Grade 5 means you've got normal power against full resistance. But as nerve damage isolates those muscles, the power drops. It drops to grade 3, where movement is only possible without resistance, all the way down to grade 1, which is just a mere flicker of movement. And finally, grade 0, complete paralysis. By rigorously testing and scoring these muscles, doctors can actually foresee and potentially intervene before any irreversible deformities take hold. Now, what's really interesting about this next part is how doctors use some surprisingly low-tech tools to uncover these muscle failures, like a literal book. In the book test, the patient is asked to hold a book between both hands, keeping their thumbs straight on top, while the examiner tries to pull the book away. Look closely at the patient's right thumb here. It's flexing at the tip and hyperextending at the base. This clawing motion? That is a positive from its sign. It brilliantly exposes weakness in the adductor pollicis muscle, which tells us there's damage to the deep branch of the ulnar nerve. Similarly, we've got the card test. A firm paper card is placed between the patient's extended fingers, and they're told to squeeze it tightly while the examiner tries to pull it out. Failing to hold on to this simple card reveals weakness in the palmar interossei muscles. It's a subtle clue, sure, but a vital one. It's an early warning sign that the patient might soon develop severe grasping difficulties, which obviously affects their ability to do everyday tasks like eating or holding small objects. Finally, Section 5, Essential Bedside Tests. Let's confirm those suspicions. Let's see how all of this builds to a definitive diagnosis. The slit skin smear is widely considered the simplest and most valuable laboratory test for leprosy, and it boasts an incredible 100% specificity. Usually done on the right earlobe or the eyebrow, the clinician cleans the area, grips the tissue, and makes a highly precise incision. We're talking exactly 5 millimeters long and 3 millimeters deep. Then they turn the blade at a right angle to scrape the tissue fluid from inside the cut. That fluid is smeared onto a slide, fixed over a flame, and stained to reveal the bacteria. Once it's stained, doctors examine the smear under a microscope using an oil immersion objective. But they don't just look at it, they actually count the bacteria using Ridley's logarithmic scale. This scale mathematically grades the density of the bacilli, both dead and alive. A 1+ means finding just 1 to 10 bacilli across 100 different microscopic fields. A 6+, on the other hand, means finding massive clumps in every single average field. It visually organizes the severity and infectivity of the disease, which completely guides the treatment plan. Next up, we test the invisible wires of the autonomic nervous system using the histamine test. See, normal autonomic nerves are sheathed by Schwann cells. In leprosy, M. lepra basically parasitizes those exact Schwann cells. If you inject histamine into normal skin, you get a small bump called a wheal, surrounded by a wide, red, 2-centimeter flare caused by dilating blood vessels. But in leprosy-affected skin, because those autonomic nerves are damaged, the red flare is visibly stunted or just entirely absent. And testing this autonomic nerve function is absolutely critical because these nerves are often impaired even earlier than the sensory nerves we tested earlier with the monofilaments. That's exactly where the sweat test comes in. Normal sweat glands are activated by sympathetic nerves, so doctors inject a chemical like acetylcholine into the skin. Normal skin is going to sweat, which turns applied starch blue, or turns special bromophenol paper blue. But the affected skin, it stays completely dry. It lacks that crucial sweat gland activation. Just another vital piece of the puzzle uncovered. And that brings us to the core of this medical detective work. Through this really meticulous combination of sensory tests, nerve palpations, muscle strength assessments, and microscopic smears, leprosy simply cannot hide from a trained clinician. It is highly detectable. But it does leave us with a provocative final thought, doesn't it? Knowing the autonomic nerves fail first and sensory loss closely follows, the stakes are incredibly high. The diagnostic tools are right there at the bedside, but how quickly can we train more eyes and hands to spot these subtle clues worldwide before lasting, irreversible damage takes hold? It's a massive challenge, and it makes this ongoing diagnostic investigation more vital than ever. Thanks so much for joining me on this explainer.